Today we are asking the million-dollar question. Do men hate women? Have men always hated women? Because you would think providing healthcare would be the bare minimum since everyone deserves it, but this doesn't seem to be the case. The gender bias you will find when it comes to healthcare is unhinged. Across the globe, women spend more time in poor health, pay higher out-of-pocket costs, and often receive less value from their insurance than men, even when pregnancy is excluded. Systemic barriers, gender bias in medical understanding, and economic inequality mean women's health needs are frequently underprioritized, leading to gaps in care, delayed diagnoses, and higher rates of chronic illness. Despite healthcare being a basic right, these disparities persist, revealing how deeply gender inequality is woven into even the most fundamental systems. Welcome to the Medical Deep Dive. This is a truly vital topic, one that touches on the very core of fairness and how we care for human health. Today, we're going to really peel back the layers on this issue. We'll explore how our understanding of the human body has developed with certain biases baked in and what the consequences are for countless individuals. We're going to cover some key areas that truly shed light on whether medical science truly has a gender problem. We'll begin with a look back at how certain health explorations were historically structured. So, let's unpack our first point. 1. Historical exclusion of women from clinical trials. What exactly happened there, and when did things start to shift?
Yeah, it's a pretty striking reality when you look back. For decades, really, these huge efforts to find effective treatments for major life-threatening conditions, cardiovascular issues, cancer, even neurological disorders, they largely left out half the population.
Half the population? You mean women were just not included?
Often, yes. Imagine trying to understand a disease that affects everyone, but then choosing to ignore data for a massive portion of those affected. That was essentially the situation. Until 1993, in the United States at least, there wasn't actually a requirement for women to be included in many major clinical investigations.
1993, that sounds incredibly recent. Why were they excluded?
Well, it often wasn't necessarily out of malice, but sometimes from a maybe misplaced concern. The thinking was that hormonal fluctuations in women could complicate the results, make the findings less clean, harder to interpret.
So to simplify the study, they just focused on men.
Exactly, which meant that medical insights were overwhelmingly based on male physiology. The male body effectively became the assumed standard for everyone.
So the male body was treated as the universal blueprint for humanity, effectively sidelining any physiological differences women might have. That's a significant oversight, isn't it?
It really is,
Yep.
precisely. If you aren't examining how a new therapy or a diagnostic tool affects women, you simply cannot have a complete picture. You don't know about its safety or its effectiveness for literally half the people it might be used on. The assumed baseline was a male body. So any physiological distinctions unique to female bodies, think about how medications are metabolized differently, how diseases might progress, what side effects could pop up, those were just not observed or accounted for systematically.
And this isn't just theoretical, right? It has real-world consequences.
Oh, absolutely.
Yeah.
Directly impacts how treatments are designed, how they're prescribed. And even after that 1993 policy shift, progress has been incredibly slow. For instance, there was a thorough examination looking at over 1,000 clinical investigations between 2016 and 2019.
Okay.
So not that long ago. It revealed that women, even though they make up over 50% of the population, constituted only about 41.2% of participants on average. Still a significant gap.
That's nearly, a decade back, and still, women were significantly underrepresented. Where do we see these gaps most prominently today in modern health exploration?
We see these disparities in some really critical areas of health. Take psychiatric conditions, for example. Women represent about 60% of patients diagnosed with many of these conditions.
Right.
Yet, when you look at the studies testing new treatments for those same conditions, only around 42% of the participants were female.
Wow. So the group most affected is the least studied for new treatments.
In many cases, yes, or at least underrepresented. It means a huge group of individuals suffering aren't adequately represented when we're evaluating safety and efficacy. It's similar with cancer. Women account for 51% of cancer patients, but their inclusion in corresponding clinical investigations was still hovering around 41%.
And the implications, if a treatment works differently or has different side effects?
That vital information just gets missed. Or, maybe worse, it gets discovered much later, after the treatment is already out there being used on patients in the real world. Even in areas like cardiovascular device assessments. And remember, heart disease is a leading killer of women. Only about 29% of participants in those studies were women. Just 29%.
That's incredibly low.
It is. This persistent underrepresentation is a major barrier. It stops us from uncovering essential differences between men and women and how safe or effective new treatments and health tech really are. It's fundamentally about making sure medical advances truly benefit everyone, not just, the segment of the population assumed to be the default.
It's really sobering to think that even today, women's unique physiological responses might still be something of an afterthought when developing vital treatments. If you or someone you know has participated in a clinical investigation, we'd be interested to hear about it. What was your experience like? Did you feel your specific characteristics, like your gender, were fully considered? Let us know in the comments.
Okay, this leads us directly to our second crucial point. 2. Generalizing male data to women. What does it really mean that medical sciences predominantly use the male body as the default? And what are the implications of doing that?
Yeah, the historical tendency has definitely been to see the male body as the standard, the sort of universal blueprint for understanding human health.
Right?
And this meant that insights gained from examining men were often just applied directly to women. It basically sidelined the unique physiological and hormonal characteristics that women possess.
And you mentioned this isn't just about reproduction. Not at all. That's a common misconception. It impacts the understanding of all sorts of body systems and conditions. Think about how a heart attack can present very differently in women compared to men, different symptoms, sometimes less obvious ones, or how certain medications are metabolized, how they interact within a female body. It's broader than just reproductive health. The underlying assumption, often unconscious, that a normal human being is implicitly male, well, that unfortunately permeated the foundations of medical understanding. It's really about systemic and, frankly, cultural variability influencing scientific practice.
So it's not just about what is studied, but then how symptoms get interpreted and how care is actually delivered. You're saying men might get more thorough treatment for the same conditions.
Precisely. The consequences of this generalization are pretty profound. It can lead to men being investigated and treated more extensively for a really wide variety of conditions, even when the symptoms reported are of similar severity in women.
Can you give some examples?
Sure. When we look at conditions like, say, coronary artery disease, Parkinson's disease, irritable bowel syndrome, even things like chronic neck pain or knee joint arthrosis or tuberculosis. Findings have consistently shown that men often receive more thorough diagnostic workups, more tests, more referrals, and often more aggressive treatment protocols. Consider something like psoriasis, that chronic skin condition. Even when you have similar numbers of male and female patients and similar disease severity, observations showed significantly more funds were spent on clinic-based treatments for the male patients.
Down on women.
Women often receive simpler recommendations, maybe less comprehensive self-care emollients. It's not necessarily about blaming individual doctors, but it points to a systemic issue in how conditions are approached, maybe based on ingrained assumptions about gender.
That's a powerful distinction. Does the gender of the care provider themselves also play a role in how symptoms are perceived and treated?
Absolutely. There's evidence of a subtle but significant bias there. Medical findings sometimes indicate that care providers might be more likely to interpret a man's symptoms as originating from a physical biological cause, something concrete.
Okay.
But a woman presenting with similar symptoms, her symptoms might be more readily attributed to psychosocial factors, stress, emotional issues.
The old "it's all in your head" trope.
Unfortunately, yes, or variations of it, sometimes being labeled emotional or even hysterical.
Yeah.
This can lead to women getting more nonspecific symptom explanations, and in some cases, even being prescribed more psychoactive drugs, which might completely miss an underlying physical problem. It's been documented men with chronic discomfort might be seen as grave or stoic, whereas women with similar experiences faced labels that delayed recognition of their very real physical issues.
That's really concerning.
And this point about the care provider's gender is critical. There was a compelling recent analysis. It looked at the Texas workers' compensation system. Importantly, doctors were randomly assigned to patients, which helps control for other factors.
What did it find?
It uncovered a really striking disparity. Female patients were less likely to be evaluated as having a continuing disability, and as a result, they received less in subsequent disability support when they were assessed by male care providers compared to when they were assessed by female care providers.
And for male patients.
For the male patients, the gender of the evaluating doctor had virtually no impact on the outcome. Same assessments, same support levels, regardless of whether the doctor was male or female. It really highlights the potential importance of gender diversity among health professionals. It could influence fair medical evaluations and the benefits patients ultimately receive. Think about it. When nearly two-thirds of current physicians are men, this workforce imbalance could unintentionally skew evaluation outcomes. We know that patient-provider demographic similarities can often improve communication and reduce those implicit biases.
That's a profound thought. If you happen to be a care provider listening right now, what specific steps do you take or think should be taken to ensure that gender stereotypes don't creep into your initial interpretation of a patient's symptoms? What kind of internal checks or reflections do you use to make sure you're seeing the patient as an individual, not just through a gendered lens? Let us know your approach in the comments. Okay, moving to our third point. 3. Underrepresentation in participation. Beyond just the clinical investigations we started with, where else do we see this imbalance in the medical world, and what's the ripple effect on our collective understanding of health?
Yeah, the issue of underrepresentation definitely goes beyond just who gets into clinical trials. It touches several other critical areas within the whole medical ecosystem. Firstly, even when women are included in health explorations, their involvement is often heavily skewed towards reproductive health.
Okay, like pregnancy and childbirth.
Exactly. And while maternal health is undeniably vital, complications during pregnancy and childbirth are still leading causes of death for women globally. This intense focus often means we neglect a whole broader spectrum of health issues that affect women across their entire lifespan.
Such as?
We're talking about major chronic conditions like Alzheimer's disease, heart disease, certain types of cancers. These disproportionately affect women. They're leading causes of illness and death for women. Yet they receive disproportionately less attention in how health conditions are explored and understood, especially outside of the reproductive context.
So it creates a gap in understanding women's health beyond their reproductive years.
Precisely. It limits our holistic understanding. Secondly, another huge blind spot is just the persistent lack of data that differentiates between male and female experiences across all sorts of conditions.
You mean data isn't separated by sex?
Often, no, or it isn't analyzed separately. If the information we collect doesn't break down findings by sex, we inevitably miss crucial differences. Differences in how diseases manifest, how they progress, how people respond to various interventions. Take something like HIV infection. Biological and genetic differences mean different disease courses for men and women. Women might show lower viral loads initially, but sometimes progress faster to AIDS. If you don't collect and analyze that data separately, you miss that nuance.
And that limits treatment.
Severely. It perpetuates gaps in our collective medical understanding and really limits the development of tailored treatment approaches. It hinders optimal care for specific groups.
Does this underrepresentation also affect other groups beyond just women generally, especially thinking about intersectionality?
Well, absolutely. And this is where intersectionality becomes so important. That's the idea that an individual's experiences, especially in healthcare, are shaped by the overlap of their different social identities, race, socioeconomic status, gender identity, sexual orientation, and so on.
How does that play out?
Well, medical knowledge, as we've said, has historically focused heavily on the cisgender male experience. That often completely overlooks the specific health needs and experiences of non-binary individuals, trans people, intersex individuals. These communities often face huge systemic barriers, sometimes even overt violence or discrimination within the healthcare system itself. This leads to them delaying seeking care and tragically results in worse health outcomes. For transgender women, for instance, the risk of HIV infection is estimated to be 49 times higher than the general population, yet their specific health needs are often neglected in broader public health discussions.
That's staggering. And what about race?
Similarly, for people of color, our fundamental educational materials have often reinforced norms based on whiteness. This leads to severe underrepresentation in illustrations and textbook descriptions. There was an examination in 2018. It found less than 1% of the images in the widely used Atlas of Human Anatomy depict people with dark complexions. Less than 1%.
That's shocking.
It is. This profound lack of diversity in the very visuals used to teach medicine implicitly conditions future professionals to primarily see patients as white. And this can, and absolutely does, lead to incorrect diagnoses, especially in fields like dermatology, where skin tone drastically changes how conditions appear. It's a foundational flaw with really far-reaching consequences.
It really makes you wonder about the impact on diagnostic accuracy for so many people. Imagine for a moment you're seeking medical attention for some persistent, undiagnosed issue. If you believed, rightly or wrongly, that care providers of a certain background or gender tended to understand your specific health needs better, what changes would you recommend at an institutional level? How could we make sure everyone, regardless of who they see, gets access to that kind of informed, comprehensive care? Share your thoughts below. Okay, our fourth key point delves into bias among the gatekeepers of medical understanding. 4. Editorial and leadership bias. How does the gender composition of those who decide what gets published and who leads our medical institutions actually impact the knowledge we all gain?
This is where the power dynamics really come into focus. Because who is at the top, who leads medical institutions and publications, can profoundly influence what health topics are seen as important enough. Important enough to be explored, prioritized, and ultimately shared with the wider medical community and the public.
And historically, those roles have been
Predominantly held by men. Across academia generally, and very specifically in the medical field, leadership roles have historically been male-dominated. Now, we have seen a welcome increase in the number of women physicians overall, which is great progress.
but not necessarily at the very top.
Exactly. Women are still significantly underrepresented in those top-tier roles. We're talking about college presidents, provosts, senior administrative positions within medical schools, hospital leadership. Just as one data point, back in 2017, only about 30% of college presidents were women. This imbalance at the highest levels, where decisions about strategy, funding, institutional culture are made, inevitably shapes the entire landscape of what we consider valuable medical knowledge.
So it's not just about the raw numbers of women in the field, but their positioning and how that influences what knowledge gets amplified.
Precisely, and this imbalance extends directly into the intellectual discourse, what gets researched and what gets published. Even with more women entering the field, we still see these disparities in who gets to author the important medical communications. Well, globally, estimates suggest less than 30% of those conducting significant health explorations are women. And when you look at actual publications, men average significantly more contributions over their careers. One analysis, for instance, showed men averaged about 13.2 published articles compared to 9.6 for women. That's a 27% gap. And this disparity is particularly obvious in senior author positions. Those are usually seen as the intellectual leaders of a project, and also among those writing the influential commentaries, the pieces that often shape the debate and future directions in the field.
So the voices shaping the dialogue are disproportionately male.
That's what the data suggests.
Okay.
And it potentially leads to less emphasis on health issues that predominantly affect women, or issues that manifest differently in female bodies, simply because those perspectives aren't as represented in the authorship and leadership pipeline.
It seems logical that if women are less represented in these influential editorial roles, insights relevant to women's health might get less priority. But couldn't you argue that academic focus just shifts naturally over time, regardless of who's in charge?
That's a fair question to ask. And academic focus certainly does evolve, but the evidence really indicates that leadership composition does play a significant role. Decisions made at the highest levels, including on editorial boards of major journals, have been consistently linked to fewer publications and less widespread knowledge specifically about women's health.
You have evidence for that.
Yes, there's clear evidence showing women are more likely to be associate editors, rather than the more powerful section editors or editors-in-chief. Those top roles wield much more influence over what content gets accepted, what gets promoted, and what ultimately shapes the medical conversation. Now, it's true that some journals led by women editors have shown higher rates of women as first authors, which is positive, but it's not a guaranteed correlation across the board.
So what's the key takeaway?
The crucial insight here, I think, is that those in leadership roles, and this includes men, need to actively advocate for contributions focusing on women's health and physiology. It means consciously challenging potential biases, actively seeking out diverse perspectives, and promoting a more inclusive approach to deciding what knowledge gets published, rather than just passively hoping things will shift organically. And there's another factor here, too, what's sometimes called the maternal wall bias.
Maternal wall bias. What's that?
It's about how motherhood, or even the potential for motherhood, can subtly impact career progression. Even if overt discrimination has thankfully decreased, implicit bias often persists. Assumptions might be made, sometimes completely unconsciously, that women with children wouldn't want certain promotions, wouldn't want time-consuming leadership roles, or maybe couldn't handle the demands alongside family responsibilities. This can lead to women being subtly steered away from those leadership tracks, and it creates a kind of self-reinforcing cycle. Fewer women are seen in top roles, which further perpetuates the idea that maybe those roles aren't really for women. Plus, the reality is, women are still disproportionately likely to spend significant hours on home and family care. Observations show women work, on average, about 8.5 hours longer at home per week than men do. This societal pressure and expectation makes work-life balance a bigger career obstacle, potentially steering capable women away from leadership and consequently reducing the chances that women's health gets prioritized at the highest levels.
If you've ever looked at the leadership in medical or scientific organizations and noticed a lack of diversity, what do you personally think is the single biggest hurdle? Is it about opportunity, those societal expectations you mentioned, institutional structures that need changing, or maybe a mix of everything? Let us know your thoughts.
Okay, our fifth point gets down to the nitty-gritty. 5. Sex bias in case reports and medical literature. How does this subtle bias show up in the actual materials medical professionals learn from, and what are the consequences when people seek care?
This one is really fundamental because these materials, we're talking textbooks, case studies, the foundational documents, they form the absolute bedrock of medical education. If that foundation is biased, then the understanding built on top of it is going to be skewed too. It's almost inevitable.
How does it show up? Is it obvious?
Sometimes subtle, sometimes quite stark. One really striking example is just how the human body is depicted visually. An examination back in 2008 looked at over 16,000 images in widely used medical textbooks.
It found that male bodies were used 3 times more frequently than female bodies
God.
to illustrate anatomy that wasn't related to reproduction, just general anatomy.
3 times more.
Yes. And another review of 17 major anatomy textbooks in Australia confirmed women were significantly underrepresented visually. And it's not just gender. Broader diversity is lacking too. Fewer than 1% of the illustrations in the very famous, widely recognized Atlas of Human Anatomy depict people with dark complexions.
Less than 1%.
Yeah. This profound, pervasive lack of diversity in the very images used to teach can implicitly condition future medical professionals. They start to primarily see the patient as male and as white. It creates this narrow, often inaccurate, default framework for understanding human physiology in all its actual variety.
So it's not just about what's missing, but also sometimes about what's actively presented in a biased way, even in the language used.
Precisely. Beyond just the images, the narrative itself, the language used, can be deeply problematic. Some analyses have found subtle, yet damaging gender bias in materials for fields like gynecology, where you might expect more focus on female biology.
Like how?
For instance, in some classic biological descriptions, male sperm has been portrayed using very active, almost heroic language. It's active, superior, powerful, like it's on a quest.
Okay.
While the female egg, in contrast, is presented in much more passive terms: docile, defenseless, dependent, waiting to be acted upon. This kind of language, even if unintentional, subtly reinforces these really outdated notions. It can affect perceptions of health, scientific understanding, suggesting a passive role for female biology, which can then bleed into broader perceptions of women's health needs and even their agency in their own health. It influences how students perceive basic biology right from day one.
That's fascinating and also pretty unsettling. How does this kind of foundational bias learned in school then translate into clinical education and ultimately into actual patient care down the line?
It has really direct and significant consequences for training. Medical students themselves have reported this. For example, some noted that male students were almost always cast in the role of patient during role-playing exercises in preclinical training.
So the default patient was male, even in practice scenarios.
It seems so in those reported cases. One student even specifically mentioned that the anatomy dissection halls often predominantly used male cadavers, again, reinforcing the male as the standard patient, the universal body. This means that medical students, and perhaps especially female students, aren't given sufficient opportunities to confidently examine and address the unique physiological aspects of women in a practical, hands-on way during those really formative years.
And this continues beyond training.
Well, think about this. When a major medical text actually suggests using a 70-kilogram white male as the standard reference point for drug prescription, that just underscores how deeply embedded this single point of reference thinking really is. Despite the huge, obvious diversity of human physiology in the real world, this lack of balanced content during training inevitably leads to a knowledge deficit. Care providers, no matter how dedicated or well-intentioned, might graduate unequipped to fully understand the different ways conditions present across genders and diverse populations.
And this implicit bias carries over.
It can, yes. Absorbed during training, it can then unintentionally manifest when they become practicing health professionals. We see potential consequences. Findings from 2018, for instance, revealed that men experiencing chronic discomfort were often perceived as brave or stoic. suggesting resilience. While women presenting with similar experiences were disturbingly sometimes labeled emotional or hysterical, labels that led to delayed recognition and treatment of their genuine physical problems. And another observation, this one in 2019, found that women waited significantly longer for accurate explanations for their symptoms in 72% of cases compared to men. 72%.
That's a huge majority.
It is. It really highlights how pervasive the impact of this foundational bias can be on actual health outcomes. It often leads to delayed or inaccurate diagnoses for women and other underrepresented groups. The consequences are undeniably real, and they directly impact individual lives, sometimes profoundly.
If you're a patient listening, have you ever felt that your discomfort or your health concerns were maybe not taken as seriously as they should have been, or perhaps dismissed in a way that felt connected to your gender? How did you handle that experience? And what do you think medical professionals could do differently to avoid those situations and make sure everyone feels genuinely heard and accurately assessed? Let us know in the comments. All right, finally, we come to our sixth point. 6, funding disparities. Even if we understand the history, the biases, and knowledge, does the money actually follow the need when it comes to women's health?
The answer, unfortunately, is a pretty resounding no. Despite all the clear statistics on how common certain conditions are in women, despite the undeniable impact these health gaps have on women's lives, their families, the economy, there's a significant and persistent underinvestment in women's health.
How significant are we talking?
Consider this staggering fact. Estimates suggest only about 1% of the global healthcare budget is allocated specifically to women's health issues beyond general care. 1%.
1%. That seems incredibly low.
It is. And within that tiny slice, the part of health exploration focused on women's specific needs, sometimes called femtech, though it's broader than just tech, receives only about 3% of the overall healthcare investment dollars.
Okay, so 3% of investment goes to femtech?
Yes, and most of that small amount goes towards fertility and pregnancy-related innovations.
So things like Alzheimer's, heart disease.
Exactly. Critical areas like Alzheimer's, heart disease, many cancers conditions that are major killers of women, cause significant long-term disability, drastically reduce quality of life. These are largely overlooked in that specific funding stream. These conditions affect millions upon millions globally, yet the financial commitment to understanding and addressing them specifically in women remains profoundly disproportionate to their actual impact.
That's an astonishingly low figure, especially given how many chronic illnesses disproportionately affect women, as you said. Does this financial imbalance also affect individual health professionals trying to get funding for their own explorations?
Oh, absolutely. This financial imbalance is strikingly evident when you look at grant opportunities for the people actually doing the health work on the ground. Women face consistent, documented difficulties in securing financial support compared to their male colleagues.
In what ways?
Well, this imbalance shows up not just in funding for the big clinical investigations, but also in sponsorships for larger projects, and even just general support for independent health exploration. For example, some analyses indicate that fewer women even apply for the lead roles on grant opportunities, which is a barrier right there, maybe due to some of the systemic issues we discussed earlier.
Right, the pipeline issue.
Exactly. And while the funding rates for women, meaning the percentage of applications that get approved, can sometimes be higher in very specific areas or certain funding rounds, the overall proportion of total funding dollars that women receive often remains notably lower.
So even if their applications are good, they get less of the total pie.
The data suggests that can be the case. It points towards a systemic issue where, even if individual applications from women are successful on merit, the total financial commitment directed towards women-led or women-focused exploration significantly lags behind the actual need. It's complex. It involves who applies, how applications are reviewed, and perhaps the perceived value or priority of the proposed work within the existing structures.
So given these deep-seated funding inequities, what are some of the proposed solutions? What policy changes could help ensure money genuinely flows where the need is greatest in women's health?
Well, the conversation definitely needs to shift beyond just awareness. We need active investment and real systemic policy reform.
Like what?
One key recommendation is to establish truly transparent procedures for allocating funds, procedures that are genuinely unbiased. The decisions on what gets funded should be based purely on the scientific merit and the potential impact of the proposed health work, period. The gender of the applicant shouldn't factor in at all.
Easier said than done, maybe. How do you ensure that?
Part of it is ensuring robust diversity on the committees that actually award these grants. Bringing in more women, yes, but also individuals from varied backgrounds, ethnicities, different types of expertise, different lived experiences. This helps counteract potential implicit biases and ensures a more comprehensive, equitable evaluation of all proposals. Beyond just the allocation process itself, there's also a strong push for things like mandatory assessments.
Assessments of what?
Assessments to ensure that all proposed health explorations explicitly consider and aim to contribute to bridging existing gaps in understanding and care for women. This encourages a direct focus on gender-specific aspects, on health inequities, on the effect of gender on treatment outcomes. It ensures new knowledge actively addresses disparities rather than ignoring or perpetuating them.
And what about supporting the researchers themselves?
That's crucial too. Institutions need to create genuinely supportive policies. Policies that acknowledge the real challenges of balancing a demanding career in health exploration with personal responsibilities. Things like comprehensive parental leave for all parents and real, usable, flexible working hours. These aren't just nice to have, they're critical for retaining talented women in the health sector and promoting equity within the workforce. Ultimately, it really is about fostering a culture that values and funds exploration into women's health with the same rigor, the same investment, and the same sense of urgency that we see in other areas of medicine. That's how we foster true equity in health and ensure the financial commitment finally aligns with the profound human need.
When we think about the future of health, all the potential breakthroughs, what single bold change in how we fund medical understanding do you believe would have the most profound, maybe the most immediate, impact on women's well-being over the next decade? Would it be something like a dedicated global fund just for women's health? Strict quotas for funding exploration led by women? Or maybe something entirely different? We'd love for you to share your visionary ideas on this spark a conversation in the comments. Wow, this deep dive really highlights how interwoven everything is: historical attitudes, the systemic structures, even the subtle language we use, how it all shapes something as fundamental and personal as healthcare. The journey toward equitable understanding in health is definitely ongoing, and it seems like it truly requires everyone, individuals, institutions, funders, to recognize these patterns and actively work toward a future where every single body is understood, valued, and gets the care it truly deserves. So if you had to pick just one of the points we discussed today: historical exclusion, generalizing male data, underrepresentation and participation, editorial bias, skewed medical literature, or those funding disparities, which one do you think is the most urgent to address right now to start improving women's health globally? What's the one lever you'd pull first if you could? Let us know your thoughts on that too. Thank you so much for listening. Please subscribe, and as always, have a nice day or good night and stay safe. See you on the next one.